Thanks for joining the academic meeting this morning. Welcome to everyone online. So this morning's meeting is presented by Obstetric Medicine. For the students in the crowd, those online who don't know what obstetric medicine is, Charlotte is unique in that we have an internal medicine unit that looks after medical problems in pregnancy. This is because as physicians, and you can all agree to this, physicians are frightened of pregnancy. We don't understand the physiology, and we're all scared of giving Panado because of what it might do to the baby. Nothing is the answer. The obstetricians, there's one or two in the crowd, aren't too sure how to manage medical problems. So there's this gray area where patients get missed. But we're trying to fill that gap. And our speaker this morning is Professor Richards. He's been very supportive of this endeavor. He gave a version of this talk at the launch of the Society of Obstetric Medicine. He's always been quite supportive. And we're looking forward to hearing from him. Prof. Richards is Emeritus Professor of Critical Care and Pulmonology. Many of us in this room were taught by him. Many of us get shivers in our spine when someone sees an overloaded patient and says they're intravascularly depleted. And I think if those of you that were here last week who heard the rep talking about how to use an inhaler, many of us have been on the receiving end of Prof. Richards making us show him how to use an inhaler. So you are going to learn a lot from this talk, and we'll just welcome Prof. Richards and say thanks for joining us, Prof.
Thank you. Yeah, thanks very much. It's a pleasure to be here, and obviously an important topic. And of course, to remember that pregnant women also get medical diseases, which is exactly what Jarrod has been saying, that merely because you're pregnant does not exclude you from all the other diseases that potentially you can have. The only issue is that they're generally young patients, so that the diseases of old age, like the cancers, etc., atheroma, are less common, although they certainly also occur in that setting as well. So we're going to talk about asthma in pregnancy. And now it doesn't work, Jarrod. Go back on that. Okay. So first of all, to understand asthma specifically, some of you might have asthma now, but some of you might still develop asthma. It's often thought that you only get asthma in childhood and that it then progresses with time and you end up getting it worse as you go along. But in fact, what it is that it arises between a genetic potential in order to develop asthma, and then it's driven by specific molecular mechanisms, which are called endotypes of asthma. And the manifestations of how it appears in each patient is called the phenotype. So you have genotypes, endotypes, and you have phenotypes in terms of the mechanism. That looks awful, but you need to actually start to know what that is. You've got the type 2 inflammation over there, and you have non-type 2 inflammation. This has become very relevant because many of the therapies we use are now dependent upon what type of endotype you have. So in asthma, for example, we would be measuring the number of eosinophils in the serum, because if they're more than 300, you are more likely to benefit from an increase in your inhaled steroid or a biological therapy. And I'm going to be talking about biological therapies in asthma next week. So this is the classical one where you've got antigens to which you are allergic. You go via TSLP, you've got Th2 cells. That goes to your interleukins 4, 5, and 13, which activates your B cell, and that causes the accumulation of eosinophils and mast cells with the release of mediators. This one here is quite common, and particularly common in smokers who develop asthma, where the neutrophil is in fact the most commonly involved organism. And unfortunately, that category is less likely to respond to inhaled corticosteroids. So the neutrophil is not a good cell to have if you're going to be using steroids to control the disease. So that's what your airway looks like. There's a normal airway, one can see over there. There, in fact, is a remodeled airway that occurs if you haven't used your inhaled steroids. And please remember that asthma is always an inflammatory disease. And if it's always an inflammatory disease, you always need to use corticosteroids. People often say, even now, people say, steroids, oh my goodness, what will this do? But if you don't, you end up with an airway that looks like that, where you've got smooth muscle hypertrophy, constriction, hyperresponsiveness, increased mucus production, etc. Now, when your patient comes to ICU and they get ventilated, people often expect that patient to get better within 24 hours, so-called asthma breaking. When it breaks, you'll be better. But in order for you to get better, you actually have to decrease the size of this airway, decrease the inflammatory component, and only then will your patient be able to breathe properly. So it is a slow process when you actually are getting better or being treated in an ICU as well. To get to that type of airway takes a significant amount of time. And I am talking this Saturday, it's tomorrow, at the pulmonology update. I'm talking about ventilating the asthmatic patient, and that obviously is another important one there. I just want to talk about the so-called hyperreactivity. And what does that mean? It means that to certain stimuli, you will overreact, or in fact, you'll react to non-specific stimuli and not necessarily an allergen. So there are the airways I've just shown you. There's the normal airway with the radius of that size. There is your asthmatic area with a smaller radius. If I have a radius that is larger, there's my radius there. If I have a radius which is larger and I decrease that by 25%, I'm going to get almost no increase in airway resistance. But if in fact I start off at a smaller radius, I'm then going to have a significant increase in airway resistance because of the fact that the radius is equal to, the resistance is equal to 1 upon the radius to the power of 4. So that is the graph, and that's why you have hyperreactivity, which means that smoke during the period when you have been challenged and you are now inflamed, you will react to non-specific stimuli like smoke, cold air, exercise, etc., which are not allergens, but those are non-specific stimuli, which now will cause you to overreact as well. Asthma occurs in 3 to 8% of pregnant women. The severity may worsen, it may improve, it may remain unchanged, always said to be the thirds, but in fact that really isn't the case. It can be any proportion of what happens in the phase of pregnancy. There is a small but significant increase in complications, a 15 to 20% relative increase. Please take note, because if your complications are relatively small and you have a relative increase, it isn't a large increase. It's not that that is an absolute increase. Relative increased risk of perinatal mortality, preeclampsia, preterm delivery, or low birth weight. And severe asthma has a 3 to 100% relative increased risk of the same complications. Pharmacological therapy essentially is the same, and it's very critical that you try and persuade your patients to remain on their therapy during their actual pregnancy, because concerns about the risks of medication are outweighed by potential adverse effects of untreated asthma. And that often is what people don't take into account. They're scared of using other drugs in case it harms the baby, but your health also has the potential to harm the baby. We know that there are a number of hormonal and endocrine changes. Increased progesterone will stimulate your respiratory center. That increases minute ventilation. Increased minute ventilation, you get a respiratory alkalosis. A respiratory alkalosis, much like hyperventilation, is going to make you feel a bit dizzy, and if it really occurs to any great extent, you can even get hypocalcemia with Chvostek sign and with carpal spasm, etc., occurring if it occurs significantly. So physiological dyspnea occurs in 25% in early pregnancy related to that increase in the progesterone. You feel dyspneic because of that respiratory stimulation. And asthma-like symptoms can also occur from relaxation of the lower esophageal sphincter. We know that reflux can actually mimic asthma symptoms, particularly in asthmatics, merely by causing irritation and sometimes laryngeal spasm when you actually get reflux occurring as well. And another thing that occurs is pregnancy rhinitis. That is a non-allergic, self-limited condition associated with an increased placental growth hormone. And then hormonal changes also affect the upper respiratory tract, and the airway mucosa was estrogen-mediated hyperemia. That means you are now increasing the vasculature, edema, hypersecretion, and mucosal friability. And think back then that if this occurs on top of an airway which is already inflamed, you potentially will decrease that radius even further. And as a consequence, the patient will have even a greater symptom burden as well. So what about the actual physical changes that occur other than necessarily the hormonal changes? The uterus displaces the diaphragm upwards by approximately 5 centimeters. This leads to an increase in the AP and the transverse thoracic diameter, enlarging your chest circumference. The diaphragm function, however, is not reduced. And that's because of the fact, and I'll explain a bit later, that you maintain the dome of the diaphragm. In patients with COPD, the flat diaphragm is inefficient in contracting. If you maintain your dome, this then allows much better contractility to actually occur in the chest. So, because of the fact that your diaphragmatic excursion is not reduced, your FVC, FEV1, your ratio, and your peak flow are unchanged or modestly increased. The anatomical changes, however, progressively decrease the FRC. So what is FRC? The functional residual capacity, the amount of air you have in your lung at the end of your normal tidal volume. So if you're breathing along and then at the end of your normal tidal volume, you then go, and you blow everything out. You'll blow down to residual volume, but the residual volume and the expiratory reserve volume are the actual FRC, but that will decrease. So your expiratory reserve volume will decrease. The residual volume may decrease, but that's certainly not a consistent one. Vital capacity and total lung capacity are unchanged due to the increase in the thoracic circumference. So I mentioned the diaphragm, its ability to generate tension occurs or increases secondary to muscle fiber lengthening and to the maintaining of that dome. The apposition to the lower ribcage increases its radius, there's that dome, and that's due to progressive enlargement of the lower ribcage to give space to the lungs themselves. This results in an increased tidal volume. So if we have a look at this diagram over here, if we look at progesterone over here, that increases oxygen consumption, and it gives you a feeling then of dyspnea, and of course a respiratory alkalosis because you are going to breathe more to compensate. If we look at the progesterone, it increases your tidal volume as well, with the same effect as that over there. Breathing frequency will remain much the same because you've increased your tidal volume, but your minute ventilation goes up, increased arterial PO2, decreased PCO2, respiratory alkalosis that actually occurs. The enlarging uterus will displace the diaphragm upwards. This is increases the zone of apposition, which is going to then enhance or maintain diaphragmatic contraction, and this increases the lower rib cage's contribution to driving the tidal volume itself. The abdomen dimensions and the increased rib cage dimensions will lead to an approximate same total lung capacity, but your inspiratory capacity will often increase as well. And of course, these link as well by the fact that the tidal volume is going to be increasing. So if we look at that from a practicality point of view, there is your normal respiration as you breathe in and out. Then that is your inspiratory capacity at that point from the expiration at the end of your tidal volume. That's the inspiratory capacity. The vital capacity is going to be from forcing all your air out and now increasing it to your maximum. And that over there is your expiratory reserve volume, and that's your residual volume over here. And as I said before, the functional residual capacity is the combination of residual volume and expiratory reserve volume. And as you can see, your residual volume decreases, but not dramatically. You can see that your expiratory reserve volume goes down, but within that space, you can see that your inspiratory capacity actually maintains itself, and that is how it compensates for this enlarging abdomen, which would be impacting normally on the respiration itself. So asthma in pregnancy, if symptoms do worsen, it's most likely in the second and third trimesters, with a peak incidence in month 6. Peripartum and postpartum exacerbations are less frequent, but certainly they occur. You expect it during the pregnancy itself, and we still like to use the asthma control test. So for those of you who are not pulmonologists or physicians who don't use it, a very simple test, asking a patient how they are in terms of their control, is absolutely critical, because we have made the mistake of saying, Mrs. Smith, how are you feeling today? And she says, I'm fine. But she might not be, because patients themselves are generally not aware of their level of control or otherwise. So all that you do is you ask 5 questions. How often did asthma keep you from getting your normal activities done? How often have you had shortness of breath? How often did your asthma symptoms wake you at night? How often have you used your rescue medication? And how would you rate your asthma control? If you get 5 for all of those, you've got marvelous control. If you maintain it with, there's 5, that would be 25. If you maintain it within that blue range, which would be 20 to 25, then you are still adequately controlled. But in the red, you are then not controlled anymore at all. And it's critical that you ask. One of the problems, of course, is compliance with low-dose inhaled corticosteroids. Patients don't like to take their steroid because when you puff it, nothing happens as far as they're aware. If you take a short-acting beta agonist, you can feel my airway opens. This must be the good medicine. So I always would put down the 2 inhalers in front. We'll talk about that, the 2 inhalers in a moment. Well, I put the 2 inhalers down in front of the patient. I say, which is the important one? And invariably, they will point towards the beta agonist. And you say, no, this is the important one. And they say, but it doesn't do anything. It does, but it is a slower process in terms of maintaining and decreasing the amount of inflammation that you have. Current evidence indicates that adherence is low, and patients take less than 50% of the recommended doses. And as you increase, and not only that, it decreases with time to as low as 10 to 15 of patients refilling their prescriptions. Some of that, and we notice it in private patients, is that towards the end of the year, their medical aid is finished. And because it's finished, they just don't fill their prescriptions, rather make sure the family has sufficient of their medicines in that period of time as well. And just from a diagrammatic point of view, this looks at asthma deaths per 10,000 patient years. And if you look at the number of canisters per month of the short-acting beta agonist, now it's amazing that some people might use as many as 7, but you do see them puffing away like crazy. Look how the mortality increases dramatically as you increase the use of the number of canisters of short-acting beta agonists. And we probably shouldn't sell short-acting beta agonists anymore, the so-called Ventolins or Baritics, all of those. We should not be selling them. I'll tell you what we should be doing in the future. Canisters per year, as you actually have an increase in the number of canisters used per year, then you look at the rate of death from asthma also decreases. So there's a direct relationship, increased mortality with short-acting beta agonists and decreased mortality with your inhaled corticosteroids. Absolutely critical. And in pregnant patients, they look at that steroid and say, oh, what's going to happen to my baby with that steroid? In fact, that is far better, as I mentioned, than having a situation where your asthma is not controlled. And just to show you as well, looking at SABA prescriptions, this is looking at the odds of symptom control. You get a decrease, 67% likelihood of having at least partly controlled asthma relative to those who are only using 3 to 5 or 1 to 2 prescriptions over the period of a year. And similarly, as you increase your SABA prescriptions, So you increase 92%. When you're using more than 13 a year, you increase the asthma exacerbations by 92% as well. So just to show you, they're not good medicines. And just one other thing, and I'm talking next week about biologics. Patients who are on biologics are those who have the worst asthma control. They're on maximum therapy. We'll talk about maximum therapy, but they're on maximum therapy and they are still having exacerbations. So their quality of life must be absolutely awful. So in the UK, a number of patients, 45 difficult asthmatics, they, in this setting, so I'll start with this one, of 59 patients, 47 were eligible for the so-called novel therapies or the biologics. 32 had electronic monitor data utilized. In other words, on their actual inhaler, they attached a little device which showed whether it was being used or wasn't being used. And non-adherence occurred in 16 of those, 50%. And that included 7 with possible non-adherence, meaning that those worst asthmatics who were eligible for biologics, actually 59% were not compliant. And we don't understand that because you ask your patient, are you taking your therapy? Of course. You know, you've all seen that little movie with House, Dr. House, where he says to the patient, are you using your inhaler? She says, of course. Do you think I'm an idiot? And so he says, well, why don't you show me? And she takes her inhaler and she goes, like so. And that is not that funny because it occurs quite frequently as well. So 2 strategies have developed. The first one, which has been used for ages, has been a fixed dose inhaled steroid and a long-acting beta agonist. Then you use intermittently your short-acting beta agonist, and at the same time, you were supposed to use an inhaled steroid. Trouble is, nobody does that. They'll carry their short-acting beta agonist, but they won't use their inhaled steroid. And the MART therapy, and that means the maintenance and reliever therapy, where you've got a fixed dose of inhaled steroid and formoterol. There are other rapidly acting LABAs. Why you've got to use formoterol is because that was the first of the rapidly acting LABAs that actually open the airway as fast as a salbutamol. So you then use fixed dose of the inhaled steroid formoterol and intermittent inhaled steroid and formoterol. And if you've got very mild asthma, you don't use a fixed dose at all. All you use or keep on you is your dose of inhaled steroid formoterol, and you take a puff of that when you are actually having symptoms or not. So it's established this therapy for moderate to severe asthma with a reduced relative risk of severe adverse events by 25 to 40% versus fixed dose steroids versus that technique, and particularly in those with a history of severe acute exacerbation. So what about mild asthma? Mostly people with mild asthma don't take anything, or they carry their short-acting beta agonist. Then they get an exposure and boom, they end up in hospital as well. But patients will adhere poorly, therefore, to their regular steroid because they're not that symptomatic. And this increases the risk of exacerbations overall. So when we look at short-acting beta agonists alone, severe acute exacerbations are reduced by 60% in an open-label study in patients using SABAs alone, greater reduction in exercise-induced bronchoconstriction, and versus maintenance low-dose steroid and intermittent short-acting beta agonists, severe acute exacerbations were non-inferior in 2 large double-blind studies and superior in 2 open-label randomized controlled trials. The inhaled steroid dose, when utilizing that technique, is 25 to 50% of the maintenance dose of inhaled steroid, and no difference in terms of the scores or in terms of the measurements of inflammation. So you can dramatically decrease steroid use, which might be important in pregnant patients, maintain the same level of control, and keep those patients out of hospital as well. LAMAs, which we still don't have access to in the hospital, you wouldn't believe it, but we don't, are important in terms of maintaining those difficult asthmatics who are already on regular inhaled steroid and long-acting beta agonists, and recommended in all of the guidelines. The actual interaction is not fully understood, but they all do, in fact, act on calcium-activated potassium channels and protein tyrosine kinases. And just to show you, categories of patients who, as I mentioned, are already on maximal therapy, some that were on medium-dose steroids and some that were on high-dose steroids, had added to their therapy a LAMA, a long-acting muscarinic antagonist. And they added glycopyrronium was the one, and tiotropium was the other one. And in all the settings, you can see in these very difficult asthmatics, here we have the trimaran study, there is the trigger study, and in all of these you can see this is the FEV1, which increases as soon as you add the LAMA relative to the patient on steroid and LABA alone, and that's mimicked in the trigger study. And similarly, when we look at moderate to severe acute exacerbations, are decreased with the LAMA, decreased with the LAMA, and decreased with the LAMA. So it is an additional therapy. It's not going to fully cure your asthma, but you know, the cardiologists have got it better, because in fact, they get a new medicine, and that decreases the incidence of some form of ischemic event by 10%. But not absolute 10%, relative 10%. Everybody says, oh, wonderful, let's us use this new medication. Even though we show similar and greater relative improvements with certain drugs, we are told, no, that's not a significant increase, and therefore you shouldn't actually use it. So what about corticosteroids in pregnancy? They do reduce exacerbations, and if you stop them during pregnancy, you will increase risk. And part of that is related to that estrogenic hyperemia that occurs in the airways themselves, with a decrease again in the radius that I want you to remember about, the radius of that airway with an increase in the resistance that actually occurs there as well. Most data is for budesonide, but whatever steroid they're on, if they're well controlled, continue that inhaled corticosteroid. The data for fluticasone are reassuring regarding a low birth weight, small for gestational age, preterm birth, and for congenital malformations. They've not been demonstrated to be increased. And oral corticosteroids, however, are associated with a 2 times increase in preeclampsia and a minimal incidence, 0.4% of oral cleft, particularly if taken in the first trimester. Now, sometimes you have to give oral corticosteroids, but you must be aware that there are potential harms. So we would certainly try to optimize therapy in terms of the inhalants that we are using, but we don't always get absolute control. We would try not to use oral steroids. Most experience in the LABAs are with salmeterol, but formoterol has had no reports of any teratogenic or embryocidal effects at low doses. Remember that the original LABA, the salmeterol, has a slow onset. So you can't really use that one as a reliever, which is why the formoterol is so useful in combination with the steroid, because it opens the airway at the same rate as a salbutamol. So that is why we would prefer to use that one. But there have been no reports of harm there as well. And there are many new ultra long-acting beta agonists, and those are things like olodaterol and vilanterol. I'm not quite sure why we shouldn't make names that nobody can remember either. Everybody else certainly seems to, for example, in cancer literature and all the rest there as well. But anyway, animal data suggests low risk, but not a first choice because of the fact that we don't yet have enough experience with the olodaterol and the vilanterol, etc. LAMAs, tiotropium has been around for a long period of time. Spiriva has been around for a long period of time, and that decreases exacerbations, as I mentioned, in severe asthma, especially if you've got fixed airway obstruction. Do remember that remodeling I showed you early can become permanent if you don't treat them appropriately. So patients with asthma who have remodeled can in fact have fixed airway obstruction that resembles COPD, which is why it's so important to treat these patients with a steroid early when they are young. And by the way, they don't decrease the size of the child if you're using inhaled steroids. They do, however, slow the growth. But if you look at twins using therapy, they end up at about the same height. But even so, you try to limit the dose of the steroid. And the good way of doing it, that would be via MART, maintenance and reliever therapy, as I mentioned to you earlier. So the experience in pregnancy and lactation is minimal, but they've been continued during pregnancy without concern at all. And just to show you then what the track 1 is now saying, GINA, the actual global initiative for asthma overall, they are actually saying this is the track 1, which is the preferred track. And as you can see, it says as needed, low dose inhaled steroid and formoterol. So you don't take anything on a regular basis in patients with mild disease. That's the MART component of the therapy itself. Step 2, if you're not controlled adequately on that, you go on to a low-dose maintenance inhaled steroid. For example, you take 1 puff twice a day of that controller, and then you use another one should you have an exacerbation. So you could have then using 3 puffs a day, or maybe just 2 would control you adequately. Step 4, you would up your dose of inhaled corticosteroid. And step 5, if you're still in trouble, you're now going to add the LAMA, which we don't have yet. You won't believe it, as I told you already. You then refer to the full phenotype assessment to your pulmonologist, possibly high-dose inhaled steroids. You would then look at anti-IgEs, anti-IL-5 or 5 receptor, anti-IL-4R, or anti-TSLP. Those are biologics. And I'm going to talk about the biologics next week, because we have had access to one of those biologics to utilize in this category of patients that you can't control them. Because that's to get them off the oral corticosteroids that have all the side effects that you actually would be aware of. This is track 2 for people who don't have access to a MART type therapy, where you take a SABA, but at the same time, you then have to take a separate inhaled corticosteroid. How many people do you think take that separate inhaled corticosteroid at the same time as taking their SABA? 2 inhalers. It's not going to happen. It's not going to happen. So it doesn't work, this type of system. Low-dose maintenance steroid, low-dose inhaled steroid LABA, medium high-dose steroid, inhaled steroid LABA, and then the same thing at the end in terms of those patients who are particularly difficult to control as well. If we're thinking about other therapies, in labor, the same options for pain relief should actually be used. There isn't an issue. Prostaglandin E2 used in induction and oxytocin for augmentation of labor can be used as normal. In obstetric bleeding, prostaglandin F2 alpha derivatives should be avoided because they can cause bronchoconstriction, so one could run into trouble there. And women who have taken more than 7.5 milligrams of prednisone daily for greater than 2 weeks, you should consider parenteral corticosteroid during the labor period, because they may well worsen in that phase of the pregnancy. So your patient, if they're not controlled, think about all the other reasons why they might not be controlled before you just jack up the inhaled steroid or jack up the therapy or send them off for a biologic. Could be the wrong diagnosis. Has somebody actually done a flow volume loop spirometry to see that there is reversibility? And very often you'll find that they haven't. And I had a young patient who came to me that weighed about 15 kilograms, but he was 15 years of age. He turned out to have a web in his trachea. And all we did was we lasered out that web, and he grew like about 3 feet in the period of time from then till when I saw him the next time. And he'd been filled full of oral steroids. Remember that all that wheezes is not necessarily asthma. Have you looked at the gastroesophageal reflux? Have you treated that appropriately? Because although it doesn't make your lung function worse, it makes your symptoms worse. Have you looked at their allergic rhinitis? There was a push some years ago, which has faded away a little bit, about the one airway. This one airway that starts at the nose all the way down into the lungs, and the united airway. And basically, people will often start their therapy here. So you're taking your therapy nicely here, you forget the nose. If you put an allergen that the patient is allergic to into the nose, and you cause an allergic rhinitis, your asthma will get worse, and vice versa. If you give an allergen into the lungs, the nose will get worse. And that is related to a cytokine-mediated transfer of these inflammatory mediators between the two. Check on aspirin and beta blocker use. South Africans love aspirin. When I go into a cafe, almost always somebody next door to me is buying grandpa, and they are knocking back their grandpas, which cerebral people don't like either, but we don't like, because about 10 to 15% of people may well be aspirin exacerbated asthmatics who might have respiratory disease, aspirin exacerbated respiratory disease. Environmental allergens are common, and we need to think about those. Occupational, I see a number of patients from Lever Brothers, for example, and they make soaps, and many of their soaps contain enzymes to remove stains, and those enzymes that remove stains are highly allergenic. Platinum mine. Myself and my colleague, we were doing a study on platinum mining, and we went into the platinum mine and we saw they actually made it. It's actually a dreadful experience. You have to strip naked, and go through this little passageway. And on your way out, you also have to spread your bum so they can see you haven't put platinum in there at the same time. But it also potentially will give you asthma. And that asthma persists even after you've removed them from the stimulation of it as well. Smoking. You've got no idea how many asthmatics actually smoke or smoke other things. Dacha and tik and who knows what else as well. Depression and obesity all contribute as well to control of your asthmatic, and that's a specific phenotype of asthmatic. And then think also possibly small airways inflammation that your standard inhalers are not actually going to reach. And then some form of oral therapy or a very small particle inhaler might actually be of value there as well. And the most important one still remains inadequate therapy, specifically compliance, or they don't know how to use the device. When in the wards, I asked the patients, show me how you use the device. Almost all of them get it wrong, almost all. And the same thing applies to your nasal steroid. And I've said that the nasal steroid is critical in terms of your control as well. What do people do? They squirt. And when they squirt, they wet the front of their noses over here. But in fact, your sinuses go from your nose to your ear. So the only way you can use your nasal steroid is to bend over, put it into your nose, bend away from the septum, and now spray. So you're spraying towards the ear. Don't let them do this. It doesn't help. Okay? So very critical. And of course, the technique of inhalation is also absolutely critical as well. So your patient with asthma in pregnancy can be and should be well controlled, and you shouldn't have any problem with them whatsoever. But make sure they're compliant, make sure they're not scared of the steroid because of the baby, and make sure, therefore, that they continue their therapy. So thanks very much.